Asleep? Can you put your hands up if you're asleep? So I'm going to talk about resuscitation. How many of you resuscitate babies? Does anybody not resuscitate babies? Because you can go to sleep if you don't resuscitate babies. And just on that, how many of you use T-piece devices? T-piece devices, neopuffs, or I wouldn't. And how many of you never use T-piece devices? Oh, okay. Hardly worth giving my talk then. Okay, so where am I coming from? My hobby, passion, research, interest, probably for the last 10 years, has been trying to understand neonatal resuscitation. Having been a neonatologist for many years, and suddenly all the bureaucracy comes out and we are told we have to get certified to be resuscitator, even though I'd resuscitated many babies as anybody running the course, and so I put my name down for the course, and they say, you can't come on the course. Oh, why not? I need to get the certificate. You will only argue. And they were right, because a lot of the time I was frustrated by the dogma. The dogma is, if the heart rate's less than 100, you do something. Oh, really? Sounds good. What's the data? If the baby's blue, give it oxygen. Well, is your blue the same as my blue? And how blue is it got to be blue, and so on and so forth. So we started doing research in Melbourne looking at neonatal resuscitation, and I'm only going to show you some of the things. And these are the things I'm really going to go through. So initially I'm going to go on from where Alan was, PEEP from birth, absolutely vital to improve oxygenation, so not quite the same as his. The way to do that is to use a T-piece. You've got to use oximetry, I'll show you why. I'm not going to actually talk about this bit because I've got to give another talk on using oxygen at birth and face mask positioning and CO2 detectors. Now, Alan's given you a brilliant talk about CPAP and PEEP and given you lots of background information. I'm not so clever at all that laboratory stuff, but I can tell you that CPAP is just magic. It does everything a neonatologist would like, except make the coffee. If you give it at birth, it helps establish and maintain an FRC, and I'll keep coming back to this theme, but the only time in life where you have no gas in your lung is the moment you're born. You've got fluid up to here. You've got to get that fluid down, get the fluid out, get the alveoli open, and you've got to form an FRC. If you're a little preemie baby, you've got ribs made of jelly, muscles made of tissue paper, you might work hard, but it's not very easy to get all that fluid out and get your lungs expanded. And I will show you good data that PEEP and CPAP are absolutely the key to getting the lungs open. Now, I'm a simple guy. Oxygenation is all about surface area of the lung. Get the lungs open and oxygenation improves, okay? It's not about breathing, it's about getting the lungs open and just having some gas in there, and that diffuses quickly. So if we can get the lungs open with CPAP and PEEP, we improve oxygenation. Hey, then the baby goes pink a bit quicker, the heart rate goes up, the neonatologist begins to relax, he doesn't want to do anything because the baby's starting to look good. Alan talked a bit about surfactant, and we've all been very involved in surfactant for a long time. And there's old data, not very good, but nevertheless it's there, that if you just ventilate with no PEEP, the lung gets expanded and collapse and gets expanded and collapse, and you lose surfactant. If you can hold the lung open, you conserve the surfactant. The other thing that lungs keep collapsing and expanding, get injured, protein leaks onto the surface and injures the surfactant. So various ways, keeping the lung open, what little surfactant the babies have got is conserved. Of course, it opens the upper airway. It opens the lower airway. It makes it easier for the baby to breathe, improves the compliance. Everything improves. So just by CPAP, the baby can breathe easier. Alan showed you information reduces lung injury and inflammation. And of course, now we've seen it reduces the need for ventilation. So CPAP is terrific. Now let's just talk about, this is all about resuscitation. So I'm going to show you some lamb studies, premature lamb studies done in Melbourne by Megan Probyn as part of her PhD. And this was looking at the AADO2, the oxygenation. And if you're not used to AADO2, if you've got an AADO2 down here, you're doing pretty well. And if it's up here, you're in big trouble. Okay, and this was looking at CPAP pressures. No, well, these are PEEP because we have to ventilate and anesthetize these animals. And so these are ventilated, anesthetized, very premature. And 0.48 of PEEP, 0.48 of PEEP. So we just concentrate on this side. Little lambs delivered, put on the ventilator, and no PEEP. Within that first 15 minutes, we could hardly oxygenate them. 4 centimeters of PEEP, we reduced the oxygenation, improved the oxygenation significantly. 8 PEEP, we almost halved the oxygenation within that first few minutes of life. And I put up here 10 minutes, but actually it was down by 5. I put up 15 minutes, it was down by 10. Now this study was criticized, this one here, because we said, oh, you haven't done any antenatal steroids, you haven't done any Curasurf or whatever. And so all I put up here is the Curasurf. Curasurf given at about 2 minutes. So they were ventilated at different levels of CPAP. And you will see that although the Curasurf helps, well, it doesn't help if there's no CPAP, okay? Little bit here, but overall, what is improving the oxygenation is, hey, the PEEP level, all right? Now, this is anesthetized premature lambs. I don't think we can necessarily abstract from that to the babies, but isn't it interesting that the 8 centimeters had pretty well halved the oxygen requirement. So if you want to make your babies look pinker and better, give them PEEP right away. So I'm just going to show you a little video now of a real life baby, I hope. So what I want to illustrate here is, at this point of the talk, is this baby is immediately newborn little Premi, about 26 weeks. It's already been put in a polythene bag. I'm not going to talk about that unless somebody wants to discuss it. But immediately it has a face mask on attached to a near-birth system, any TP system, so it is getting CPAP right from the get-go, from the first few breaths. This baby needs help getting its lungs aerated. Don't wait minutes and minutes staring at this poor baby struggling. Give it CPAP to help it get going. Now, one of the important things about CPAP is you want the pressure to keep the baby going. The neonatologist here can't stop giving the baby the odd inflation. Doesn't actually need it, but that's the nature of neonatologists. And as you'll see in a minute, the nurse can't help but put the hat on the baby, even though it breaks the CPAP seal and the pressure comes off. And if the pressure comes off, the baby will lose some lung volume. She's got to do it. She's been trained to put the hat on. And I've really got a thing about, if you're going to give CPAP, right at the beginning, you must give it. Don't keep taking the masks on and off and having a look and seeing what's happening. You want that pressure to help get the FRC. And here, I'll come on to in a minute, is using pulse oximetry to see what's going on. So many of you have been around a while and might have seen some of these pictures, but I think these are some of the most fantastic pictures I'm going to show you. the first time that it's been possible to actually image the lungs aerating. And these are little premature rabbits done by the team headed up by Stuart Hooper, who's Professor of Physiology in Melbourne, with a good Australian term, a whole swag of physiologists and physicists and mathematicians all behind to try and make sense of the pictures. Okay, we have 27-day rabbit pups. Why 27-day rabbits? Rabbits go to 31. These are immature rabbits. These were exactly the same type as rabbits who were used in all the early surfactant studies. So here is the rabbit being ventilated with a PIP of 35 and with no PEEP. Okay, and you see the pressure down into the airways, but as soon as the pressure's off, it all collapses and is lost. There is a little bit of air getting trapped by fluid bubbles in the peripheral airways, but there really is not much evidence that the alveoli are actually opening up or distending during this time. If we go on for a long time, they will get better. So that's what it looks like if you use your ladle bag or whatever and you ventilate without any PEEP. Exactly the same study, not the same animal. That one went to the way of experimental animals. Okay, here's what happens if you put on 5 centimeters of PEEP. The airways stay open. The fluid is being pushed out into the periphery. There's that blush of air getting into the periphery and the alveoli opening and beginning to form the FRC. So, you know, I feel having shown those really, this is PEEP, they're ventilated, they're anesthetized, they're paralyzed, but I think the principles are that if you apply an end pressure to help push the fluid out and produce lung volume, then that can only be good for gas exchange and all sorts of other things. So preterm infants, CPAP, please start with CPAP if you can, or PEEP if they are ventilated, absolutely vital to aid lung aeration, lung stabilization and oxygenation immediately after birth. And so many, many places are still resuscitating babies with self-inflating bags. The self-inflating bag, I'm afraid, needs to be consigned to the museum when it comes to resuscitating preterm babies at least. Why use a T-piece? Well, because they're good at giving CPAP. Now, I'm saying CPAP here, not PEEP. You can do, as was done in that video, you can put the mask on the baby's face and you can give a spontaneously breathing baby CPAP right from the start. You can't do that with a self-inflating bag. It is very difficult to do it with a flow-inflating bag. You can also give prolonged inflations. Now, the increasing thoughts, fashion, that actually one of the ways to really get the lung open quickly is to give a long inflation to start with, help get the fluid out of it. You know what pressures and PEEP you're giving, whereas all the other devices it's very difficult. So you inflate for a certain time by occluding the hole. And if there's a big mask leak, and I'm going to come on to that in a minute, the PIP and PEEP will not be achieved. So they're relatively easy to use with instruction, but if it gives anything, it gives CPAP and it gives PEEP. Now, one of the key things that people must be taught with using TPEEP devices is right before you start setting it up, choose a flow. You can choose anything you like as far as I'm concerned, 6, 8, 10 litres, set the PIP and the PEEP. Use those during the resuscitation, but never change the flow, because if you do, the PEEP goes right up, can even get to 20 centimetres with some flow transducers. And why would anybody change the flow? Because they're not getting the pressures. And they think, oh my God, I can't ventilate this baby, it's a bloody machine, I'll turn the flow up. If you can't get the pressures, it's because you've got a mask leak and you need to adjust the mask hold. So that's just what the recording looks like with a T-piece. And with a self-inflating bag, you can see down here it spends more time with no pressure than it does with a high pressure, and so you can see why, if we believe in CPAP and PEEP, that is not a good device. All right, so here's just a series of studies done with little 27-day rabbits, and looking at the lung volume, the change in lung volume. And I just want you to look here. This is over about 2 minutes. These little animals are being inflated, and we are now measuring lung volume with plethysmography. And you can see that with each inflation here, not only is the tidal volume building up, but the FRC is building up as well. You can use exactly the same pressures, you can build up the tidal volume, but you get no FRC. Now here I was very interested, Ariane Tepa in particular, who's the author of this paper, was interested in prolonged inflation. And there's no doubt that if you give a prolonged inflation, you can actually get the lung open quicker. But you must go on with PEEP. It's no good giving a prolonged inflation and not giving any PEEP, otherwise you don't get the FRC is just lost again. Now you might look at this and say, well, prolonged inflation of 20 seconds is really not much different from giving PEEP. There is a lot more data that they're developing at the moment which suggests that there is good effect of both a prolonged inflation and PEEP. But if there's one takeaway message, is you must give PEEP. So here's a study done by Ariane Tepa and published in Pediatrics in 2007. And it's an interesting little study, 207 babies less than 33 weeks, so they're quite big, some of them, in Leiden, randomized before birth, and they had the T-piece device, a 10-second inflation at 20 centimeters through a nasal tube to give CPAP. You haven't got to give the CPAP through a face mask, that's just what I was showing there. Or they had bag and mask ventilation repeatedly and only got the CPAP when they went to the NICU. Good old-fashioned sort of resuscitation. Of course, some babies who didn't manage needed to be intubated and ventilated. They were fairly few. And what are the results? Of the 10-second inflation and the CPAP, and here you are, they're quite big babies, half of them got intubated in the delivery room in this group. About a third down were intubated in the first 72 hours. Days of ventilation was down by about a third. Moderate to severe BPD was halved. Now, so that combination of a long inflation of CPAP, much better than old-fashioned bag and mask ventilation in this particular situation. Was it the inflation? Was it the CPAP? We'll never be able to dissect that out, but certainly the combination looked pretty useful. Okay, now there is a bit of folklore in neonatal medicine that we have to intubate these little babies because they don't breathe. Well, Colin O'Donnell, who's been a very prolific researcher in this area, looked at lots and lots of videos that had been made and showed that they do. And he showed that 80% of very preterm infants either cry or breathe after birth. And the extrapolation is, well, look, they're trying, we should do our best to help them, and that's where CPAP comes in. So I'm just going to show you, if it'll go, a series of little video clips just to illustrate what happens to preterm babies after birth. If it'll go. Oh, won't go. Just let me try that again, because that's quite fun if it'll go. Oh. Doesn't go. Never mind, plenty more to talk about. Okay. No, don't worry. Okay, Alan has shown you some of the, about the COIN trial and support trial. There are now actually 6 trials of various varieties comparing CPAP with intubation or surfactant in the delivery room, starting at, or just after, starting at different times. And I've tried to put them all together on this slide, and it's quite difficult. But with a COIN trial, you've heard, randomized to CPAP or intubation, And basically intubation rate was halved by going on to CPAP. Surfactant was just about halved. Death or BPD, similar, but certainly no worse on CPAP. Pneumothorax, whoa dear, up, significantly so. Days of ventilation, actually statistically lower, although you would hardly imagine looking at that. So, support trial then. This is CPAP, intubation and surfactant, and again very similar sort of numbers. I couldn't get out quite how many of them did get, these all got surfactant, it wasn't clear there. Death or BPD, Alan's shown you that. Pneumothoraces, no different. And in fact, if you look at, I believe, various international databases, for the sort of babies we're interested, the pneumothorax rate is roughly 6%. And my personal belief that this was just a bit of a statistical quirk. No difference here. Okay, there was a study done in Colombia, not Columbia, New York, the country of Colombia. Bigger babies, CPAP versus inshore, and what happens, the CPAP babies are about third to half getting intubated. I put here 100% with quotes because they actually say it wasn't anywhere near that, but of course they all had to be intubated to get their surfactant. And I think it's a bit of a fudge if people in the inshore business say, well, of course they weren't intubated. Hey, how did you get the surfactant in? You intubated and bagged them and ventilated them for a little bit, even if you put them on CPAP. Death or BPD, no difference. Pneumothorax rate here actually was increased. Here, days of ventilation, similar. The Vermont-Oxford study, that's not been published yet, is it? No? What? Impress. This is a big study, and Roger Soll has given me permission to show the data. 3 groups, CPAP, intubation and surfactant, or inshore. And here, look at the big difference between the intubated and the other, how many were intubated, how many got surfactant, death or BPD, no difference, comes out again. Pneumothoraces, no real difference. Days of ventilation, I couldn't get out of the data I had. And then the CURPAP study, basically CPAP as against inshore, and here again we're similar in percentages. If you start on CPAP, somewhere around a third to half of the babies actually get intubated at the end of the day. No difference in death or BPD. And wow, look, they've got more pneumothoraces in the surfactant group. Probably a statistical quirk, but so, you know. So should we give, if you've got a nice little baby on CPAP doing well, do we really need to intubate it and give it surfactant? Now, many of you will tell me, look, there's randomized controlled trials of surfactant showing how good surfactant was. It reduced mortality, reduced pneumothoraces. We're obliged to go on with it. But those trials were 20 years ago. The babies were only intubated. CPAP at birth just was not on the horizon for anything but 1 or 2 centres. Only 10% got antenatal steroids, and the caesarean sections were almost all done under anaesthetic. This is very different from the practice today, and I suggest we can't extrapolate that data to our stable babies on CPAP. Intubation and giving surfactant can be difficult and destabilize a baby. I could show you all sorts of videos of people struggling to intubate babies, even experienced neonatologists, and the baby's heart rate and saturation dipping down. Early extubations, it's a bit of a guessing game. So I got this baby intubated, I've given it surfactant. Yes, the protocol says I put it on CPAP. But what happens if you've had to give it morphine, or perhaps you haven't given it morphine for the intubation, you just crashed the tube in? If you give it muscle relaxants, what are you going to do about that? Yes, you can really only intubate and give them surfactant and extubate them if you've done it without any drugs, or you're going to try and reverse the drugs. The other thing is that we've now got randomized trials, but there's a long, long history of historical reports of people saying, we tried CPAP, and look, the babies are doing as well or better than if they're ventilated. So my belief, and coming out of most of this data, is that we should really only intubate and give surfactant to babies who fail CPAP. Oh, golly. So when has CPAP failed? If you want to start an argument amongst neonatologists, try and define when CPAP fails. All right, well, let's start with the easy bit. The baby's not breathing. It'll die if you don't ventilate it. The CO2 is high and rising. Pick a figure. 60 millimeters of mercury, 65 millimeters of mercury. I say it's rising because there are a number of situations where we get levels up here where actually soon after birth it was even higher, but it's coming down, so don't take the first blood gas. Or somebody's been leaning on the chest while they're putting in the umbilical catheter, or the baby's actually, got other problems. And here is the biggest problem for argument. The FI2 is rising, and we will give it surfactant if it fulfills some predefined criteria. All the trials have different things. Some people not, we won't give it till 70%, others are intubating at 30%, not surprising. These people intubate far more babies than these up here. But a comment that was made this morning is please make sure the prongs are in the nose, make sure they're the right size, make sure the nose has been cleared of snot, keep the mouth closed if possible. Actually, it's pretty well impossible, but I have to say that. Make sure the baby's in a comfortable position. And if CPAP at 5 is not working, try a higher pressure, particularly if you've got an X-ray and there's not a pneumothorax. You may well find there's a bit of a whiteout and the X-ray and the baby are telling you, hey doc, I need a bit more help getting my lungs expanded. So here we are. You will get bored with all this by now. Formation of FRC and oxygenation, absolutely vital. Many babies can be treated with CPAP from birth. About half will never need ventilation or surfactant. Please don't intubate just to give surfactant. That's all old stuff now. Now, we don't know how to pick which babies should be intubated and given surfactant. And Alan had his nice slide, the good ones, the bad ones, and the ones in the middle. And we need some more research to try and know how to pick the winners and losers right at birth. So if we know that a baby is going to get sick and need intubating, well, let's intubate and give it surfactant early. If we know that it's going to manage on CPAP, let's go. And at the moment, we don't have any good indication. CPAP does not reduce BPD despite all our beliefs and hypotheses. Pneumothorax, probably not a problem. We've got another paper just come out about pneumothorax, not at birth, but over the first few days, showing that cohort study showing that pneumothorax was no more common in babies treated with CPAP. And as Alan said, other outcomes are no worse than with ventilation, and in fact, they are, if anything, slightly better. All right, change of tone now. Pulse oximetry during resuscitation. So here's a pulse ox just put there so you can see the values. Here's baby nicely being looked after. Stethoscope's lying in the bed. I don't think anybody actually picked it up because you've got the numbers. So let's just go into a bit like that. Now, there was a belief in neonatal medicine that you couldn't use pulse oximetry during resuscitation because it took about 3 minutes or more to get a decent display. And Colin O'Donnell did this study. Massimo, well, he did various things, but he showed at the end that this is the way to get the fast display. Turn the oximeter on, doesn't have to be a Massimo. Turn the oximeter on, put the sensor on the baby's right wrist or hand, then attach the sensor to the oximeter, and from connection you'll get a reading within 16 seconds, and from birth about 70 seconds, but of course it depends how long you fiddle around before trying to get the sensor on. So you can get pulse oximeter reading within a reasonable time soon after birth. Now, although I'm going to show you data from the pulse ox, I'm going to concentrate on heart rate because there's a whole nother talk on oxygen. So it's interesting that although there's a lot of dogma about heart rate and resuscitation, there was absolutely no data. Where does this, if it's less than 100, you need to ventilate the baby come from? Somebody's made it up. It's a nice round number. We looked, we can never find anything other than early NRP guidelines saying that this is what should be done. So anyway, Jennifer Dawson set to and studied a whole lot of infants' pulse oximetry, excluded any baby from this particular study who'd had any resuscitation, put on the Massimo, got the signals every 2 seconds, only analysed those where there was no problem with the signal, and she had 468, mainly big babies, but some down to quite small, very few who had no resuscitation at birth. A third of them were PREMS, 2/3 term babies. You can see all the rest of the things. From birth to the first data, 74 seconds, bit of a big skew on there, but you can get there. Within 90 seconds you can get data if you want to. So Jennifer produced centile charts. Here's heart rate, 0, 100, I've put the line in, going up to 180, and these are, there's the 50th centile, the median, 50% are normally below that, 50% above. Here's the 10th centile, 10% of normal babies are below that, 90% above, etc. And what amazed us with this data, and other people who've seen it and who say we don't believe it, but I believe it because we've spent ages trying to work out what's happening, is that at 1 minute, half the babies have a heart rate less than 100. These are not sick babies. These are babies who had no oxygen, no resuscitation, nothing. Okay. By 2 minutes, we got about, yes, at 1 minute there was 50%. By 2 minutes, there's still about 10%. And they're coming up fast. But really, they're in transition, these babies. They've got to get their lungs open, get the fluid down. If you watch the videos of these babies, they get born, and the baby's sort of, oh, golly, where am I? What's happening? I better start breathing and get going. And it can take them a minute or two to really get going. And I'm sorry for the North Americans in this, but the NRP saying at 30 seconds you've got to do this, and 30 seconds you've got to do that. We've hardly said hello to the baby and a minute's gone past. And I think this shows really that just give the baby a bit of time, okay? And the key thing is, all right, the heart rate's 60. Oh my God, that's terrible. Oh, well, it's coming up, guys, coming up. We can relax. Now, I mean, I just put this in, comparing PREMS and terms, and I don't want to go into every minute, but you can see the significance values down there, big differences, but actually the numbers. So the PREMS are very slightly slower, but not that you're ever going to take any notice of. And the Caesars are very slightly slower too, but not that you're going to take any notice of, which is good, so then you can use the same charts for everybody. And I have one message to you. Pulse oximetry is wonderful for the dynamic changes in heart rate. Okay, so here's a little baby. This is just the heart rate. Neopuff, bag and mask as it were, to CPAP. Okay, heart rate's right down here. Oh, it's probably almost what we expected. It's coming up. Whoops, going down. Watch out. Oh, you're doing something up here. It's coming up again. We're winning, we're winning, we're winning. Okay, so because you can see the changes every 2 seconds, you've got much more dynamic. Let's get rid of this business. I'll listen with the stethoscope every 30 seconds. I'll count for 6 seconds and multiply by 10, which gives you an enormous error. Okay, put the pulse ox on. You can sit back. You can see the heart rate going up, or you can see it going down. It gives you much more control of what's going on. Why haven't we been doing it? We do it in the nursery all the time. Now we need to be taking the pulse ox to the delivery unit. I know many of you are. And if it's good for anything, it's good for heart rate. So heart rate is probably the key sign in neonatal resuscitation, best done with pulse oximetry, attained within 90 seconds, continuous, accurate display of heart rate. I haven't gone into the accuracy, but I'm sure you'll appreciate that. Auscultation, intermittent, every 30 seconds, and may interfere with resuscitation. How many of you have been there trying to listen? People are bagging, can't hear anything. Can you stop bagging? Can you stop chest compressions? You can forget all that once you've got this on. And people say, it won't work in babies who are very sick. Well, you can actually, it works in almost all. We've had good readings of babies born with a hemoglobin of 3 grams and babies who are seriously asphyxiated. You can tell that it's working because you can see the plethysmographic signal. Now, if you'll allow me, again, my third thing about what we should be doing, you've got to give CPAP, you've got to use a pulse ox. What about ventilation? So here's a young Irish guy bagging a mannequin, if you'll be pleased to hear. And how good are we at mask ventilation? Now, again comes my thing about neonatal resuscitation training. You all do it, I'm sure you've all done it, okay? So come along, Dr. Job, just bag them up. Well done, you pass, you're good. Nothing measured, all subjective. Yes, you might see a bit of chest rise on the thing, but you know, we're doing it badly, I'm afraid. Just let me ask the audience a question. This bag here is a 250 ml bag. Why do we need a 250 ml bag when the tidal volume of a baby is 3 mils per kilo? Anybody got an answer to that? Nobody got an answer. Oh, you all use them and you're all... I tell you why, because the mask leak is so big that you've got to squeeze 250 mils to get in about 20 mils. Okay, so bag and mask ventilation. The mainstay of neonatal resuscitation, when I say bag and mask, it's sort of euphemism, could be T-piece, of course. Myth, it's easy and can be done by anybody after a short training session. Reality, difficult, even experienced operators get it wrong. And this probably leads to ineffective resuscitation, death and disability. So this was a mannequin study. People criticize that, you can't do it on a mannequin. We got it on babies, I'll show you in a minute. So consultant pediatrician, 62% mask leak. That's you guys. Look at the standard deviation, 34%. 2 standard deviations. Some senior consultant neonatologists had 100% mask leak and came away from the testing session, thought they'd done a good job. Okay, others, of course, the far end, were doing very well and hardly had any leak. Okay, nurses are pretty well as good. The junior doctors are not surprisingly not very good at all. So mask leak during ventilation of a mannequin is actually fraught with problems, particularly leak, and is an unrecognized problem. Okay, now one of the things I'm going to be going on about now is that we need to be seeing what's happening. So here's pressure, that's easy. Here's flow in and out, flow in, flow out, flow in, flow out, flow in, flow out, and here's tidal volume. And the tidal volume is good, in and out, in and out, in, out, resets at end expiration. And so what's happening here, you can see the flow in is getting more, the flow out is getting less. The mask is coming off the baby's face, coming right off the baby's face. So that from here on, this is the leak, this vertical stroke down here, okay, and the person who was resuscitating the baby had no clue that the mask leak had suddenly developed to that length and was going on happily puffing. Now, there is a belief that with the neopuff, if you maintain the pressure, then you won't have any mask leak. And see, the pressure only fell off when there was really 100% leak. The peak pressure is not a good sign. Here is another real recording from one of my consultant colleagues in Melbourne, who will be nameless, who struggled to resuscitate this baby. And afterwards we said to the person, so how did you get on? Oh yeah, I did all right. By that time the baby was in the nursery after lots of things had happened. How fast do you think you were going? Oh, I was going 60 a minute. No, you weren't. You were going 120 a minute. And you had a over 90% mask leak. So that's the tidal volume coming back out. You can see on the flow trace there's virtually nothing coming back out. Looks a bit like your NIPPV trace. Here was somebody, you know, they're going so fast they're not even getting a peak pressure before they're taking their thumb off. Completely unsatisfactory mask ventilation, and the person was unaware of what their problems were. So we've investigated mask holding techniques. This is with a ladle mask. There are different holds with different masks, but the key thing is that actually you mustn't hold it round the rim or the skirt. It buckles and leaks. You really want an even pressure down, but the most important thing is chin lift. Chin lift, pull up on the chin as much as you push down, and you've got to have an even pressure. Anyway, so they studied, Fiona Wood and Louise Owen studied mask techniques. So here's the ladle round mask, the Fisher and Paykel mask. The Fisher and Paykel came to see me and said, we got a leak-free mask, and I said, oh yeah, let's test it. Okay, so various holds, stem hold, two-part top hold, rim hold. You see, this reduced the leak considerably. So this technique, a finger either side, pushing down evenly, not on the stem, on the thing, and good chin lift. But with the Fisher and Paykel mask, particularly the big mask that collapses in the middle, it was better to hold it and stabilize it round the rim. So there are different ways of holding different masks that will reduce the leak. Now, this is using a respiratory function monitor, and we taught them all to see the signal. I like those signals I've shown you: flow, tidal volume, mask leak. And before they'd been using the Florian, this particular study, they had a leak of 20% going from 80 down, so they were already a bit better than we'd seen in the past because we'd been bullying everybody to do it properly. But now, if they did it without looking at the Florian there, but once they could see the leak, they could adjust it, and their leak was much better. So, you know, it's very difficult, and one of the things I've been preaching is that we really need to be able to show people what's happening. Okay, so they're babies, they're mannequin studies. What about real resuscitations? Well, here we have 20 babies, and here there's mask leak, and so this is for 30 seconds. This is done by Georg Smolzer, who just finished his PhD using respiratory function monitoring. And just take this baby here. During that 30 seconds, the leak went from the best about 17% up to about 90%, averaging 60%. Here, this one was good. You can see enormous variation. This one, 100% leak virtually all the time, the whole 30 seconds. Why they didn't do anything about it, I don't know. And so you can see very large variations. Now, during this study, Georg was recording this, and then at the end he said, can you tell us what sort of mask leak you had? The end of this particular 30 seconds, not the end of the resuscitation. This guy knew that he was doing badly, but everybody else pretty well estimated that they didn't have much leak. Now, some were right, and they said, oh, I haven't got any leak. Oh, yes, you have. And they really were not good at doing it. And one of the things that's come out of many of our studies, that the subjective assessment of what people are doing is very inaccurate. Now, we have had this hypothesis for a long time that the heavy hand of the neonatologist injures the lungs in the first few inflations. Some people may have a big leak, or they may not, and they're doing it well. Perhaps if I don't think I put the slide in, but anyway, I could almost go back to here. We've got some of these situations, we've got tidal volumes up to 20 and 30 mils per kilo. Oh yes, here we are. Sorry, this is right. So this is now not individual babies, but the peak inflating pressure. You all love to say, I'm going to inflate the babies with a peak pressure of whatever you like, 20, 25, 30. Okay, this is a sort of tidal volume range that perhaps we might expect, about 4 to 8. And look at how many of these tidal volumes are over 10, over 20 mils per kilo, well within the range that is likely to damage the lung. And the one message from this is that there is no set pressure. where you can get the right tidal volume. And as much as anything, it's because the babies are breathing, the mask leak's changing, etc., etc. So pressure isn't a proxy for tidal volume. I'm sorry to upset the system, but it's no good us burying our head in the sands. We can't safely ventilate with a peak pressure. Tidal volume varies from baby to baby and with time. It changes as the lung air rates, the compliance and resistance improved, perhaps when surfactants given. Changes almost more, the baby starts breathing and you're still going on giving the same inflations, mask leak changes. So we need to be targeting, changing the PIP to target the expired volume. How are we going to know that? Only by monitoring it. And just last thing, how many of you use end tidal CO2 detectors? Not everybody. Okay, well, if you do nothing when you go away, please go and buy some end tidal 2 detectors. These you put on the end of the endotracheal tube to identify endotracheal tube placement. Now, I haven't got the data here, but if you are a male neonatologist and you've intubated a baby and the baby isn't getting better, well, it's the baby's fault and not yours. Okay, and it can take them about 3 minutes before they will reluctantly agree that perhaps they haven't put the tube in the right place, by which time the baby's been bradycardic and hypoxic for a while. So it doesn't matter whether you're male or female or whatever, you put one of these little colorimetric devices on the ET tube. It changes from purple to yellow. We teach the nurses gold is good. They can remember that, okay? And it works within 6 inflations. So immediately you start bagging the baby, you can see whether it's changed colour. Detection of CO2 means the tube's in the trachea. No colour change means probably it's not in the trachea, or your inflating pressure may be too low. Some babies need a lot of pressure to get going, or the baby's dead and really there's no circulation and very little CO2 coming out. So, where should we go in the future? My belief is we've really got to talk to everybody. Nobody listens to us at the moment, but that's why I'm talking to you. It's no good going on with all this subjective stuff. We've got to be measuring and monitoring what we're doing. We've got to basically bring the NICU monitoring to the DR. Ventilation, you've got these nice ventilators that measure tidal volume, will tell you leak. We can look for obstruction, accidental extubation. If you've got the recording, you can see that straight away. You can see the pressures, the rates, the times. Hey, you can also see the baby start breathing, and we've seen a number of recordings where the people are bagging the baby one way and another, and the baby's breathing. The baby's got much bigger tidal volumes than they have, and they're all out of synchrony with the baby. And there was one very famous recording we've got where quite a famous neonatologist, many of you will know, I won't name them, was heard to say on the recording, "Baby, why don't you help me?" And no, wait a minute, that's your man to help them. So let's have good monitoring in the DR so that we can see what we're doing with oximetry and with tidal volumes, pressures, leaks, etc. Thank you very much.